Hello, I am Mark Lewis, Director of Gastrointestinal Oncology at Intermountain Health in Utah. I am here speaking at the 2023 ASCO Annual Meeting in Chicago, where we have seen some interesting new data in GI cancers that I'd like to tell you about. If I can think of one theme that sort of sums up not just GI oncology, but this entire meeting, it's that we have to take things that appear biologically plausible and promising and sacrifice them on the altar of data. And the reason I say that is I came to this meeting with a lot of high hopes, some of which have already been dashed. And it's important to admit that the whole reason we do research and then talk about it is not everything that we think is going to happen is borne out by the evidence. And what I'm actually thinking of immediately is a trial just presented yesterday at this meeting about the management of pancreatic cancer, and specifically I mean pancreatic adenocarcinoma. It is extremely well known that this is a deadly, deadly disease where we know we have to do better. And interestingly enough, one of the challenges that we face as clinicians is what order of treatment should we be providing? Because there are two things to say about pancreas cancer that we need to reconcile, one of which is it can only be cured in the operating room. The other of which is a systemic illness whereby surgery is almost never enough by itself. It's necessary, but not sufficient. So the trial that was discussed yesterday, the NORPACT trial, was looking at should we be giving chemotherapy before surgery, or should we be going straight to the operating room in patients whose cancers are clearly resectable? And the results were frankly shocking, because my bias was, okay, I'm a medical oncologist, I give chemotherapy. I think it would make sense to give the chemo first, because that does two things. In the best incarnation and best outcome, it allows the cancer to be shrunk down and make it easier for the surgeon to remove, even if they deemed it originally operable. But it also protects and prevents, hopefully, from metastasis. And so by giving the chemo first, I've always thought, well, actually, we're selecting out the patients who are most likely to benefit from the surgery. Because if you have a patient who develops metastasis, that person is almost never going to see the operating room. But the opposite already happens, where we take people to surgery first and we see them recur with metastatic disease, sometimes before they're even healed up from surgery. So that trial really takes us all the way back to the drawing board. In what order should we be going in? Should we be doing surgery first if the patient is clearly operable? Or should we be sequencing some form of chemotherapy first? And unfortunately, we still don't know. And outside the context of that particular study, there are other studies done in this area. We just don't have a clear answer yet. So watch this space. Pancreas cancer remains, unfortunately, a fearsome enemy for patient and oncologist alike. Another trial that I was hopeful would mature in a positive way, but did not, was Attraction 5. So immunotherapy has burst onto the scene in upper GI cancer in the last 2.5 years. And again, we've been experimenting as what's the right sequence, what's the right context. And Attraction 5 was looking at an adjuvant role for nivolumab in gastric cancer, and unfortunately, it did not meet its pre-specified endpoint. And so, as appealing as that sounded, we also have to let that go. Now, you might be wondering, well, gosh, where's the promise here, Dr. Lewis? What have you been excited about? Well, what I'm most excited about is that tomorrow on the plenary stage, there's discussion of the PROSPECT trial in rectal cancer. And rectal cancer has traditionally been the most and necessarily multidisciplinary cancer in all of GI, because it has required for decades now a radiation oncologist, a medical oncologist, and a colorectal surgeon. And again, we've been experimenting with the right order to go in. What the PROSPECT trial is trying to answer, and I can only presume by its plenary presentation that the answer is going to be meaningful, is can we actually omit radiation in tumors that are very, very high in the rectum? Because one of the messages of the last decade has been the right and left colon are different. They're actually embryologically different. The left and right colon are respectively the hindgut and midgut that fuse in utero, and they fuse in the transverse colon. But it gets even more nuanced than that, because maybe we actually need to manage upper rectal cancer differently than lower rectal cancer. As a general rule, the closer you get to the anal canal, the more fixed the tumor will be in the pelvis, and arguably the more of a role radiation might have. So I'm really, really, really interested in how PROSPECT is going to mature. And then finally, I think this is the era of biomarker-informed care. I literally just came from a talk that was really exciting to me. Is the GLOW trial, which was looking at an antibody called zolbetuximab, which rolls off the tongue, for a selected population of esophageal cancer. And by selected, I mean not the patients themselves, but the biomarker characteristics of their tumors. And here it's really a case of you only find what you look for. The analogy I would draw is this: there is not an oncologist at this entire conference who would dream of treating breast cancer without knowing ER, PR, and HER2. Those are kind of the base amount of data that you need, the lowest common denominator. And yet, we do not apply those same standards in GI cancers. And what I think I just learned at this conference is we have to be applying a similar rigorous standard of testing to our esophageal cancer patients. Otherwise, we will miss the opportunity to treat them. So zolbetuximab, this antibody, only works in patients that are high expressors of Claudin 18.2. So I know this just adds to the alphanumerical soup of oncology. But what I think is the future is the reflexive testing by our pathologists of these tissue specimens to let the oncologists glean the most value out of that testing. I liken it to if you're trying to wring a wet rag and get every last drop out of information. That's what we want to be doing with our tissue. So I think the future is a more perfect union of pathology and oncology, ideally with reflexive testing based on the diagnosis. We know just by human nature, by sort of cognitive bias, it's actually a lot harder than to opt into something than it is to opt out. A good example is organ donation. So in countries where you have to opt out of organ donation, they have extremely high donor rates. In states and countries like ours, where almost everyone has to opt in, those rates are very low. So I think to sort of unburden the oncologist a little bit, but also really to lean into everything that pathology can tell us, I think we're going to need some reflexive order sets where the pathologist can run these biomarkers, ideally sometimes, many times, before we've even met the patient, so we can craft a truly personalized set of treatment recommendations just for them. And those are my thoughts about this particular conference. I really enjoyed being here. For those of you that aren't here, the energy is palpable. It always feels to me like progress happening in real time, just not fast enough for all of our patients. And that is also sort of a clarion call that we need to be treating them with the fierce urgency of now. So I'm going to sign off for Medscape now. This is Mark Lewis coming to you from the 2023 ASCO Annual Meeting in Chicago. Thank you.